and good afternoon to those on Zoom as well. I'm Sam Wood, one of the internal medicine chief residents. Welcome to Grand Rounds. Thank you all for joining us today. Please join us next week for the Lissauer lectureship. The topic is going to be inpatient management of patients with cirrhosis, and it's going to be presented by Dr. Guadalupe Garcia-Sao. This week's Grand Rounds is our quarterly session from ICTR, the Institute for Clinical and Translational Research. The title is Learning Health Systems, A Pathway to Transformation, and it's going to be presented by Professor Charles P. Friedman. Dr. Friedman is joining us from the University of Michigan, where he is a professor of information and public health. He is at Michigan the Josiah Macy Professor of Medical Education, the chair of the Department of Learning Health Sciences, as well as the director of the Knowledge Systems Laboratory. He, throughout his career, has developed and studied methods to improve healthcare education and research through innovative applications of information technology, most recently focusing his academic interests and activities on the concept of learning health systems that improve health by marrying discovery to implementation and the socio-technical infrastructure required to sustain these systems. So please welcome Dr. Friedman.
I'll turn my mirror on. Okay. Okay, can you hear me okay? Terrific. Well, thank you very much. I have great ties to this area and great ties to this institution through my spouse, Patty Abbott, and some of her colleagues are here from her time at the School of Nursing as a professor there, where she ran the medical informatics, or the nursing informatics program, please. And eventually we ended up at the University of Michigan, where we both are right now. So I'm going to talk, obviously, about learning health systems. And before I do, I need to disclose that I'm the board chair of a not-for-profit that is focused on promoting learning health systems. And some of the things this not-for-profit does may come up in this talk, but primarily I'll be talking about generally what learning health systems are, and to some degree my experience with them at the University of Michigan and more widely. So let me just begin with background, a bit of a personal chronology. It's a much longer story than I have time to give now, but through a set of circumstances, when I was the Deputy National Coordinator for Health Information Technology and Chief Science Officer there, I ended up adopting the learning health system as a kind of personal crusade. And because I believed that this was the big idea that the nation's investments at the time, which were considerable, you all probably remember the HITECH Act and meaningful use and all those other nice concepts that ultimately led to the spending of between $35 and $40 billion to promote health information technology. My position was the health information technology was a means to an end, and that end was the learning health system, and that turned into my two-year crusade, which ended when I left the government and went to the University of Michigan, initially at the Schools of Information and Public Health, and using that as a platform, I organized several meetings to try to bring some rigor to the concept of learning health systems, including a national summit, which generated a set of core values, a consensus set of core values, and an NSF-sponsored workshop on the underlying sciences that must come to bear to achieve high-functioning learning health systems. Well, then I got the opportunity of a lifetime Then Dean Jim Williscroft of the School of Medicine invited me to reorganize what had been a Department of Medical Education and convert it to a department focused on the more transcendent concept of learning, with the idea being that learning can occur at many levels of scale. Individuals can learn, groups, organizations can learn, and ultra-large scale systems can learn. So this became the Department of Learning Health Sciences, which has now grown to about 30 faculty. And after 10 years as chair of that department, I will be stepping down from that position this year. So if you want a job, there's a great job open in Ann Arbor. I hope you like football. So the main points that I'll be addressing in this talk, first and foremost, is what are learning health systems? And I guess you could put an amendment on that bullet. What does Chuck Friedman think learning health systems are? And I will try to make a coherent presentation around that. Then I will answer a question that I'm sure that if I did not answer it, you would have asked me, which is, what makes this different? Because there are lots of ways, lots of models to improve health and healthcare, one of which is learning health systems. What's different? And I'm going to point to three key differences, and when we get to questions and answers and discussion, we'll see what you think of this distinction. And then finally, I'll say a bit about the Michigan experience, what we've learned from that, and take you through some of what we've done for almost 10 years now since the Department of Learning Health Sciences was formed. I'll begin with a short definition that a health system at any level of scale, and scale is going to come into this in interesting ways, becomes a learning system when, as my introduction said, it acquires the ability to marry discovery to implementation continuously and routinely. That's all there is to it. Just do it, as the Nike people would say. If you want to read more about learning health systems, one way to do that is to go to the books and monographs published by the National Academy of Medicine. They get credit for this idea, and they propagated it initially in 2017. They called them then learning health care systems. I think generalizing it to learning health systems better captures the letter and spirit of what they are. So there's a whole set of books and monographs available about it. And then turning to the shameless commerce part of this talk, there was this journal, very creatively called Learning Health Systems, which is now in its 8th year of publication. And if I do have to say so myself, has published over this time a very valuable set of articles about learning health systems. And it's a fully online open access journal, so feel free to partake thereof. So to paint a little bit of a picture of what a learning health system is, one way to think about it is with a set of anthems. And actually somebody at Penn is putting some of these to music, and we're going to release this on Spotify pretty soon. But imagine a parade. Imagine a parade and the learning health system marching band and choral group is marching in this parade down, I don't know what street in Baltimore that is, but down a street in Baltimore. What would be the anthems they would be singing, this learning health system band and orchestra? What would they be called? And one of them, and we have music for this, is what might be called Bring Us the Tough Problems. Problems that are straightforward and can be addressed with straightforward solutions. I'm not sure any of those really exist, but assuming they did, it wouldn't require learning health system methods to solve. So bring us the tough problems, and I'm going to give you an example in a little bit. The second anthem relates to the first one in some ways. Tough problems are system problems, and system problems need system solutions. And the third answer is, the third anthem is 17 years to 17 months, and I think you all know where that comes from. It's the well-documented latency between the discovery of new biomedical knowledge that could improve health and its widespread implementation and practice. And the lyrics to this anthem could go on to say, well, 17 months may not be good enough in some cases. Sometimes it needs to be 17 weeks, sometimes 17 days, and in a public health emergency, maybe 17 hours. So we could extend this, but I think most people agree that 17 years to 17 months would be a big improvement. So think about these anthems as this talk unfolds. Another way to think about learning health systems is to think about an inspector, a hypothetical inspector who comes to a health system to evaluate whether the extent to which that system is a learning health system. And of course, inspectors carry clipboards, and you can't be an inspector without a clipboard. And clipboards have checklists. You can't have a clipboard without a checklist, right? So the question here is, what would this hypothetical inspector be have on their checklist? And I'd say there'd be 5 high-level items that the inspector would be looking for. Does this system capture what it does, its own characteristics, what happens, and the context in which it happens, as data, structured data to learn from? Do they do something with that data? Do they generate knowledge that is trusted and make it available to support strategies and decisions? Do they do this continuously and in an enduring way, not in a bursty way when they're threatened in some way, but in an ongoing way? Do they have an infrastructure that enables this to happen routinely and with economy of scale? And is this part of the culture? Let me ask you a question. If this hypothetical inspector was going to try to figure out whether this is part of the culture and asked, well, why do you do this? What answer would they give if this was truly part of the culture? Perfect. Yeah, this is what we do here. This is us. Thank you. This was totally spontaneous. It's not a plant. Thank you. So coming to scale, another interesting feature of learning health systems is that they can exist at many different levels of scale. Single organizations, large and small, can achieve the status of learning health systems such that this hypothetical inspector would have checked all those 5 items on the checklist. Very, very interestingly, and probably the area of the most observable development is around the idea of networks, different institutions coming together, usually around a focused set of health problems to capitalize on their complementary strengths and function as a learning network. And I distinguish a learning network from a research network, because a research network is in the business just of generating new knowledge. That's hard enough. But a learning network, because they're committed to that marriage of discovery to implementation, is committed not only to discover, but also to do something with what they discover. And Dan and I are engaged with the PATH network, one of the PCORI networks, to do just that, see if we can move it from becoming a research network, which is the way it was established, into a learning network And there's a project within PATH called D2I, Discovery to Implementation, which is working on that. States, jurisdictional regions like provinces can become learning health systems. And there you see Indiana, which through the Reagan Street Institute has a statewide learning health system project underway. Entire nations, anybody recognize that nation? It is not an anatomical structure. Switzerland, yeah, Switzerland has a nationwide, who said that? Very good, you've been to Switzerland? Or are you just good at geography? Okay. Entire nations can become learning health systems, and Switzerland is the prominent example, but I believe that nations within the UK are striving in that direction, and other nations as well. And then we can hope and dream of a global learning health system someday. The key point here is that no matter at what level of scale they operate, they do basically the same things in a learning health system. And that enables, I'm getting a little bit ahead of myself here, but that enables a kind of scaling up from one level of scale to another, so that learning health systems that exist at lower levels of scale can compose themselves into learning systems at a higher level of scale without having to basically rip and replace. Just take out the old system and put in the new one, which isn't going to work. So, fine, what do learning health systems do? Well, the fundamental activity is this idea of community-directed improvement cycles of discovery and implementation. So what you see here is a cycle. And what you see on the left side is a discovery phase and an implementation phase, the left side and the right side. It all begins with formation of a multi-stakeholder community that is passionate, shares a passion about solving a health problem of interest to that community. It could be any problem. The key point here is that this community has a passion to solve this problem. And then once the community is formed, they begin by capturing practices data. What do we do now? And how well are we doing it? And the measurement of how well we are doing it establishes a baseline against which improvement can later be measured. Okay, then comes the non-trivial process of assembling that data, which often comes, from different sources into data amenable to analysis, analyzing the data, then bringing in what is known in the literature and from other places about this problem, because any problem important enough to invoke passion in that learning community is likely to have been studied by others. Then the results are interpreted by the community, combining, integrating the external evidence with the internally generated evidence. An intervention, one or more interventions are designed and then are implemented, following which the cycle enters its second iteration with the performance of the now changed system studied, measurements taken to see if things have improved, and the results of that process, the study of the changed system, then becomes the fuel for the next iteration of the cycle, and so on down the line. Just a quick example from our experience in Michigan, one of several projects we're engaged in, and if you want a wicked problem, a wicked system problem, you have one, an out-of-hospital cardiac arrest. I'm sitting in the shock trauma center here, so maybe this is very appropriate, and maybe because of the shock trauma center, you all do better here than we do in Michigan, but the survival rate with good neurological function from an out-of-hospital cardiac arrest in Michigan is around 10%. So there's a health problem for you. So we formed a learning community about 4 years ago with all of the stakeholders engaged, these stakeholders representing all of the stages in what the American Heart Association calls the chain of survival, beginning with what happens with bystanders, all the way through to care in the hospital if the patient makes it that far. We studied, we collected all kinds of data, 911 recordings of interactions with telecommunicators, interviews of various stakeholders, and we also accessed routinely collected clinical data about cardiac arrest. We assembled analytical data sets. We conducted quantitative and qualitative analyses on the data. We integrated external evidence because many others in the resuscitation community are working on the same problem. And then we convened, using the method of deliberative dialogue, the community, this community which had 50 or 60 members, and they came up with a completely unique idea. This was just extraordinary. No one had thought of this. 72% of cardiac arrests occur at home. Of out-of-hospital cardiac arrests occur at home. We have fire-safe homes, and 50% of the homes in the US have a fire plan. Why not have a cardiac arrest plan, especially because it's 1,000 times more likely that someone's going to die of a cardiac arrest in any house than of a fire. So we designed an intervention called a Heart-Safe Home. And we are now working on, this is where we are now, implementing the Heart-Safe Home initiative, first locally, but over time, the AHA, the Heart Association, is very interested in this more broadly. The key point here is that this marriage and the work of this learning community at which all stakeholders are represented came up with this completely novel idea. Will it double the survival rate, which would be a miracle? We don't know yet, but this is an example of the cycle in action being applied to a tough problem that's been around for a long time. So the moral here is that better health requires this and not this, which is how I got promoted and tenured. Okay, I collected a lot of data, analyzed it, wrote a paper, went back, collected some more data, analyzed it, wrote a paper. And a lot of us did this. And we did this with the best of intentions, with the assumption that somebody's going to be sitting there just waiting, like an outfielder waiting for a fly ball to land so they could catch it and put it to use. But too often, there's nobody home to do that. And that accounts to some significant degree for that 17-year latency that we know about. So the marriage, which is depicted here, basically says that this community, once you discover it, you're oath bound, you're ethically bound, you're morally bound to implement it. So if you do the one, you do the other. Or this. This is another thing learning health systems aren't, and that is broken, interrupted. Where, and I'll say more about this in a moment, where the different pieces of the cycle are supported by different entities in an institution. And this is where a lot of well-meaning efforts break down because these require handoffs. And I've got to talk about football since I'm from Michigan, and we all know what the danger is when you have a handoff. What's the danger when you have a handoff? Yeah, you have a fumble. So yeah, and no football fan likes fumbles of their own team. They love fumbles by the other team. So anyway, this is another thing you don't want to do. So you want these complete cycles, not just discovery, and you want the cycles to be continuous. Now, here's a key point. A learning health system, as a system, is more than just a collection of cycles. Cycles must be supported in a learning health system by shared infrastructure to realize economies of scope and scale. And what the hope, and it's more than a hope now in many places, is that as the infrastructure is built and the number of cycles increases, the presence of these cycles and the infrastructure supporting it transforms the culture of the institution. You can't do this by inoculation. You have to do this by a process of building and building what I see as the right thing. We call this the tornado diagram for obvious reasons. We have tornadoes in Michigan and you have tornadoes in Maryland, so this should have local meaning. Well, much to my great joy, it's taken a while, but learning health systems seem to be catching on. Slowly but surely, but with a clear uptick in the last couple of years. I've noticed that many CTSIs within Clinical Translational Science Institutes, within the NCATS ecosystem, have integrated learning health systems profoundly into their activities. I've spoken at least 10 of these places, and there's an upcoming community meeting on learning health systems on May 22nd, which will be an important event sponsored by NCATS. ARC and PCORI combine forces, in part because learning health systems are now one of 4 pillars of PCORI's strategic plan to fund to the tune of $80 million, 16 learning health system P30 grants under a program they call eSTAR. Don't ask me what eSTAR stands for. I believe Johns Hopkins has one of these grants, as do we. Harold Lehman wants to work together on this, which would be great. And then within PCORNet, and there is a lot of movement, the PCORI Research Network, there is a lot of movement around the idea, as I talked about before, of extending the mission of what began as research networks doing discovery only into learning networks that will implement what they discover. NIH is getting involved in this. NIMH started this ball rolling about 4 years ago with a program called EpiNet, which is designed to create a nationwide set of learning networks around early psychosis intervention, EPI. And coming up is the funding of a set of genomically enabled learning health system sites through the Genome Institute. These are just some of the recent developments that speak to the fact that this idea is catching on. Okay, so what makes this approach distinctive? Before I get into that, I don't know, we have a question on the Q&A. Maybe we can stop and entertain that question. You want me to open that? What was this here? No, that's I don't know how to answer that question. But if you tell me the answer, I'll say it. It's in the email. Okay, any questions from those of you here live? I'm delighted to see 84 people on the Zoom. No one wants to tell me I'm crazy yet? Yeah, the question you probably weren't heard. So the question is about, is this true communities as opposed to fabricated quasi-communities? Yeah, I'll get to that. Not in great detail, but we can talk about it more, absolutely. It's an important point. So my 3 points regarding uniqueness go to the embracing by this community of uncertainty. We go into this not committed to any strategy. We're going to discover what the strategy should be. The communities themselves, this goes right to your point, that among other things enable continuity that address this broken cycle problem. And then infrastructure, my favorite topic, but an essential one that I'll talk about in a little bit of detail. So, just repeating what I just said, the community embraces uncertainty. They're not committed to, at the outset, to any particular solution. And the key point here is that the cycle starts at 5 o'clock, down where it says yes, as opposed to 12 o'clock. At 5 o'clock, if you start the cycle there and begin by taking performance to data, you're basically institutionalizing the notion that you don't know what you're going to do. All too often, however, in cycles like this, it starts at 12 o'clock with the implementation, either because somebody in charge just comes in and says, well, this is what we're going to do. I've been working with the Saudis for a few years about learning health systems in Saudi Arabia, and one of the people just walked in and said, well, you know what's wrong with our health system? The Ministry of Health tells us what to do and it never works. There's a rationale. So, that's starting at 12 o'clock. The Ministry of Health tells you what to do because somebody there in authority wants that to be done, and it doesn't work. Continuity. The community that discovers is the community that implements. So the way it works is this. The learning community that forms at 5 o'clock is also the learning community. It just kind of changes color with the progression of the cycle. It's also the community that does the data to knowledge piece, and is also the community that does knowledge to performance. When we get into infrastructure, we'll recognize that the community may not have all of the specialized expertise to do these things. So they might bring in experts who are temporarily part of the community and bring the expertise to the community that it needs to do the performance of data, to do the analytics, and to do the implementation. But there is this core, this multi-stakeholder core of the community that stays together, as opposed to, and I hope I'm not offending anybody with these names, but in a broken cycle, you might have people called program evaluators who study what's happening now, and they might be supervised or sit within one part of the organization. And you might have people called health services researchers or embedded health services researchers who do the data to knowledge part, but they work for a different part of the organization and are different people. And then you have change implementers who are charged to take what comes out of the blue part, spanning this gap at the top, and put it into operation. But they often work for a different part of the organization under different leadership. And here, I won't belabor the football metaphor, but here you have great potential for fumbles. And it's kind of like handoffs in healthcare. This is a big challenge. So now to the point about learning communities. They are true, in order to work well, and we've learned this, I've learned a ton about this from Peter Margolis and his colleagues at Cincinnati Children's Hospital, who run a network called Improve Care Now. I encourage all of you to go to their website. They have really pioneered this idea starting 7 to 10 years ago. The whole notion that these learning communities are different kinds of things, and they function in a way that is hyper-inclusive, meaning no one dominates, all key stakeholders are represented, they are fueled by passion to achieve a shared goal, everything they do is co-produced, they are not top-down, the leadership is facilitative rather than authoritarian, and a key point that is that no group can be allowed to dominate. Here you see pictures from our out-of-hospital cardiac arrest learning community, and I think you can see some of the diversity of people who are represented. A lot of the work is done, as you see in the top picture, by dividing up into groups and having discussions. This community continues to meet to this day, and the passion that people have for solving these problems drives it forward. Now, infrastructure, this relates to, as I said, what makes the system a system. You can have a bunch of cycles, a bunch of improvement cycles that could operate independently, each being a kind of tub on its own bottom. And that can enable improvement, but it doesn't create a system. Excuse me. And by crude analogy, just to illustrate the point around the basic concept of infrastructure, you go to a simple model of what would be the case if in a city like Baltimore, and you needed to get a lot of people across water every day. Well, one way of doing it is to ask everybody to build their own rowboat. Work, but it's got a lot of problems, which I don't have to elaborate on. Or you could build a beautiful bridge that everybody can use. A bridge is infrastructure. Rowboats are anti-infrastructure. So it is with the learning health system. If it's going to work at scale and be sustainable and function in the way that it needs to function, as you'll see in a moment, it needs to have an infrastructure. So the challenge here, building an infrastructure, is how do we enable this set of simultaneous learning cycles that would, in a learning health system, you'd like to have many of these cycles going on simultaneously, each one run by its own community and addressing a unique problem to function as a domain agnostic system that really can study any problem. Just like a bridge can carry bicycles and pedestrians and joggers and trucks and in some cases trains. So here we see the tornado diagram again, and this illustrates graphically how a learning health system infrastructure might work. You see the platform at the bottom, which is the infrastructure. And what makes this socio-technical is the fact that the infrastructure consists of services provided by people, policy, process, and technology. I wish I had $50 for everybody who has said to me, well, we have an EHR, therefore we are a learning health system. Well, that's a statement tantamount to the infrastructure is just technology. But the infrastructure needs to be more than technology to support a learning health system. Made that point. So back to the rowboats and bridges, without a platform, Each cycle is truly a tub on its own bottom. It requires its own agreements, technology, staffing, analytics, dissemination mechanisms, and the like. There's no economy of scale, which means the cost of doing 10 of these cycles is going to be exactly equal to 10 times the cost of doing one. With a platform, sharing these services provided by the infrastructure, you can have big economy of scale, and the cost of doing 10 cycles will be far, far less than the cost of doing one. So bridges instead of rowboats. Now, just a little bit more about the infrastructure. I won't get into this in great detail, but we have a blueprint developed, and there's an article about it in the latest Learning Health Systems, which talks about the 10 services, the 10 socio-technical services, which comprise a learning health system. Maybe the slide is wrong. It doesn't want to display. There we go. Whoops. There we go. So picture yourself now looking down into that tornado diagram, and you see the multiple co-occurring cycles in the middle. And then here you see 10 services, which are described, and the article describes them in much more detail, arrayed to sit on the circumference of the cycle, corresponding to the point on the cycle each one most prominently supports. The one exception to this is service number one, which is in the business of organizing, starting, maintaining, and supporting inclusive learning communities, which operates throughout the duration of the cycle, but the others are arrayed so that they support one primarily one aspect of the cycle only. Now, I'm frequently asked, or it is said to me, oh my God, how can I build such an infrastructure? I don't have billions of dollars. Maybe when you were at ONC, you had billions of dollars for EHRs, but we don't have billions of dollars. Well, it turns out that for a lot of reasons, some of it generosity, and some of it thanks to government funding, there are a bevy of open source tools that can be used to assemble fairly quickly many of the services, and you probably have many of these deployed here already, of a socio-technical infrastructure. And I've just portrayed a few of them here, ranging from the International Consortium of Health Outcome Measures is one way of helping one take performance to data, to the more informatics stuff on the left side, PubMed to help access external knowledge, the Commons as a mechanism of storing knowledge, REAIM as a framework for implementation. So you don't have to start from scratch to build an infrastructure. You probably have a lot of it. You're going to have to build some of it, and some of it you'll have to pay to build, but a lot of it is available in the open source environment. So how am I doing on time? Pardon me? There's 10 minutes left in the time? All right. So real quickly, because I want to leave some time for questions at the end. The Michigan experience. Well, maybe I'm done because the clicker isn't working. So what I've learned from my own experience at my own institution and work I've done with others. Every organization starts in a different place. And to make the most obvious statement ever, you got to start from where you are. I've learned that learning health system is antithetical to top-down approaches. You can't start a learning health system by fiat. And the process of building a learning health system, if I have to put words on it, is more infiltration rather than inoculation. You can't start an IV drip of LHS serum and change the institution that way. I've learned that the idea pretty much sells itself. After listening to this talk, you may have a different opinion, but that's been my experience. What you do has to conform to your existing culture. You need a commons to get it started, and I'll say more about that in a moment. I mentioned infrastructures and creating them from what exists. A key goal is a key way to get started is to catalyze these improvement cycles, get them going. And as anybody who works in informatics knows, the IT technical part is the easy part. It's the people part that's the hard part. Probably the smartest thing we did at Michigan was to start a commons. We started this in 2016, and we call it the LHS Collaboratory, and it's actually campus-wide, and several schools from across the campus are involved. Another thing we did a few years later that was smart, we made projects the members rather than individuals. So projects that were related to learning health system activity became the members, and every project got a seat on the steering committee. That said, individuals are welcome at all activities, and we have a mailing list of 1,459 people, and typically at a face-to-face session, we get 75 to 100. And we often get in excess of 200 at virtual sessions. And we do a lot of things, speakers, poster sessions, workshops, matchmaking, where we pair up, team up different projects that are working on the same problem and running into the same challenges. So we've worked bottom up and middle out. We've got many entities doing collaborative improvement cycles. Our dental school has established an institutional goal of becoming a learning health system. We provide a lot of infrastructure services. And very recently, and I thought this was a great development, our dean of the medical school asked our stepping down chair of PM&R, who had done a lot of learning health system work in his department, if he would like to serve as a clinical champion for learning health systems at our institution. And he said, "Where can I sign?" And he has stepped into that role, and we're delighted to see that. So in closing, some sound bites. You're going to remember just a few things about this talk. Remember the marriage point, that learning health systems improve health by routinely marrying discovery to implementation. I hope you will remember the three distinctive characteristics: uncertainty, communities, and infrastructure. And finally, I didn't spend a lot of time on this, but every journey is going to be unique, but there are some general principles which I introduced that can be a guide. I didn't mean to go on quite this long, but I see we have a few minutes for questions, comments, polemics, and anything else you want to say. Thanks. Yeah.
So much for the great talk. We have a mic.
Thank you. Yeah, thank you so much for great presentation, and I really appreciate your emphasis on communities. And I'm wondering whether you could expand a little bit about some practical strategies to embed learning healthcare system into real world practice, like into like nurses, doctors, and who really practice at the front line. Because especially nowadays, there are a lot of competing priorities and so forth. So it is a really good model, but I'm wondering, is there some strategies that we could use to really disseminate to practice?
Right, right. So when you pursue a cycle, an improvement cycle, it's very, very important that all of the key groups, particularly groups that are going to have to be challenged or inconvenienced or made to work harder, at least initially, to get this going. By being sure that every group has a voice, nothing that is a non-starter will be pursued. It'll just never get to that point. I wouldn't underestimate the power of passion. I call passion the fuel of the learning health system. And when people get into it and they begin to discover, hey, this can really make a difference, things that not cynical people, but perfectly straight and narrow, up the middle, realistic people would not have expected to have happened. I was at a group in Vancouver. I made 2 trips to Vancouver about 2 years apart, and I made a first trip, and what I was hearing from the nurses it was actually a provincial meeting, that no, we're all unionized and we'll never be able to do this, and it means we're going to have to work extra hours and we're not going to be allowed, and all that. I go there 2 years later and they're doing it. They found a way. They just got engaged and they found a way to make it work. And the reason is they were passionate to solve the problems they were working on. I know it kind of sounds like I'm having a bout of magical thinking here. Go to the Improve Care Now website and listen to their story about work they've done with young adults with inflammatory bowel disease and how they mobilize this whole community around that. And I encountered, when I visited with them, parents of these kids who retired early to work on this learning community. It's a fascinating social phenomenon. So and go to their website, read some of their papers. Okay. Is it possible to engage in LHS work using research dollars, frameworks, and expected deliverables, or does the how need to be separate? Yeah, it's possible, but obviously you have to be careful and clever. What we did with out-of-hospital cardiac arrest, as one example, is we got the learning community started, we got the data collection started, and then we went to the American Heart Association with a program project grant, one project of which was the learning health system approach. And we wrote something into that grant which I had never seen funded before. Give us $100,000 to implement whatever it is we decide to implement. Can you imagine sending that to a funding agency? I almost was embarrassed to send it. I couldn't stop laughing because I thought, well, they did it. They approved it, and it just suggests that this is, if we're creative, we can find ways to get external support for learning health systems. The fact that the NIH, which is a research institution, is now beginning to fund learning health systems, and ARC, which is a research organization, more applied in their orientation. So, but still, a research organization, are funding learning health system activities are a step in the right direction. What you probably can't do is get an R01 to do a learning health system well reviewed by a study section, especially if you say we want $100,000 to implement whatever it is we learn. But who knows? what is the evidence for the lack of top-down hierarchy working best for the learning health system? What is the evidence? I don't know. I started my career as a physicist, and as a physicist, sometimes you're guided by theory. And I just think there's a lot, I think there's two kinds of aspects to this. One is there's a lot of good social science theory. Speaking to this, I would point you to Paul Batalden's work about co-creation in healthcare, other papers about new models of collaboration, a wonderful book by Dee Hock about, this sounds tangential, but it's very relevant, the founding of Visa and how he got a number of banks that were mostly in the business of putting each other out of business to work to be convinced that cooperation, that the credit card business is something that's best done pre-competitively. But as long as he did it right, as long as he did not let any one bank dominate, he was able to make this work. So there's a lot of documented theory and practice from other domains that speak to this. And the other piece that speaks to this, and I can point you to many articles in the Learning Health Systems Journal, which are experience reports that speak to how they made this approach work. So, so these are experience reports, including one by Peter Pronovost in Volume 1, Issue 1, that talk about exactly this. So there were a lot of experience reports speaking to the viability of this approach. Yeah.
Hey, Chuck. So one question I have, do you think the external groups, stakeholders for health systems, whether it's CMS or accreditation agencies or others, are they appropriately supporting the learning health system concept? And I'll say because of the short cycle time that they expect, that the quality improvement people seem to have to move so fast sometimes that I think they don't come into it necessarily with a clinical equipoise. I'm not sure whether it works, or that they have what they feel that they have the time to look at the evaluation. So I'm just wondering, could we, are the external groups incentivizing health systems to be learning health systems to the extent they should be?
Of course, I will say the answer to that is no. But there are a few points to make. And one is the very realistic point that there are problems that are on a continuum from being total system problems like cardiac arrest to being problems where, if you think about the Swiss cheese model, really the problem is the hole in one piece of Swiss cheese. I'm not sure you need learning health system methods to correct the location of that, keep things from going through that hole in the one piece of Swiss cheese. But when 6 or 7 or 8 pieces of Swiss cheese are in alignment, it's harder, probably as a power function of the number of pieces of Swiss cheese that are affected. So I think the secret sauce here is to the culture change that a learning health system can bring about will probably change the way even relatively straightforward problems are addressed. But those cycles can run rather quickly, and they should be allowed to run as quickly as they need to. We have a new chief quality officer who is a big proponent of learning health systems. She wants everything done yesterday, which is great. But she also recognizes that there are problems that can't be solved that way. So it's like anything else in life. You gotta know when to hold them and when to fold them.
All right. Well, thank you so much, Dr.
Thank you.
Freeman. Really appreciate it.